Hi everyone, welcome back. Now we are going to discuss about few diagram based stuff related to the subject general surgery. As a diagram based stuff has a primary role in deciding your rank. And of course, as the saying says that when you remember anything with a graphical representation, either with a diagram, which is related to some memory based stuff, you can retain it for a longer duration of time. So always my open suggestion for you is whenever you have the possibility of a diagram, whenever you have the accessibility of a diagram, make sure you try to retain the subject or a concept with a diagram, either with your hand or either from the textbook or either from any other source. It is always mandatory to retain the things with diagrams so that apart from answering diagram based questions, you can answer the normal question also with a retained diagram in your mind. And the second logic from the paper setter point of view, or my point of view, like how the paper setters will think, how I think when I'm giving a question paper for you. For example, if I'm planning to give 10 diagram based questions or 20 diagram based questions, what my basic logic is, more than half of the questions I'm going to give easy. For example, if I give an Adams class for you, 99.99% of students will go right answer for that. If I give an activator for you, talking about ortho, okay, 65 to 70% of the students will go for a right answer. If I give a WHO probe for you, 95% will go for right answer. If I give a Williams probe for you, 60 or 70% of the students will go for the right answer. It is a basic nature that when we give an easy question, most of the crowd goes for the right answer. When most of the crowd goes for the right answer, the question can logically cannot identify the student what the paper setter really required. Means paper setter always think to filter as many students as possible with some easy questions and some to drop the difficult questions. So as I have said, given some examples, most of the easy questions will not play a role in the examination. But of course, you have to show best accuracy for the easy questions and good accuracy for the difficult questions. So basing upon that ideology from a dental student point of view, I have selected few diagram based stuff right now for you. Let's start the discussion. Hope you know this, at least you have remembered the name, that is Ryle's tube, which is also called as Nasogastric tube. So in this tube you'll have some markings. Okay, you'll have different markings at different levels or holes at different levels. Okay, so next one to make a notice, they regularly ask this question, which is repeated for the medical people in the AIMS, that is the how to estimate the nasogastric tube length. Okay, nasogastric tube, naso means nose, gastric means GIT, right? So it has to travel from the nose, that is from the tip of the nose to that of the GIT. Okay, so how you can estimate is before inserting the tube, you have to estimate the length from the tip of the nose to the ear and from ear to the xiphisternum. This is how you have to estimate the nasogastric tube. It is the length from the tip of the nose to the tip of the ear plus from the ear to that of the xiphisternum. If you calculate both of these distances, this is 1, this distance, and the 2. If you calculate this 1 and 2, you're going to get the estimated nasogastric tube length. So there will be, I already have given that there will be markings. Okay, 40 centimeter marking is GIT junction, 50 centimeter marking is the body of the stomach, 60 centimeter marking is pylorus, and 65 centimeter marking is duodenum. So these are the markings that are present on the nasogastric tube, and these are the markers that represents the areas. Next, uses. Okay, there is something called a saline load test. Okay, by using this saline load test along with this tube, you can confirm the gastric outlet obstruction. It is also useful in diagnosis of fistulas like thyroglossal fistula, tracheoglossal fistula. And it also helps in providing the nutrition in head injuries and maxillofacial trauma cases. It also helps in assisting the free and total acid in the peptic ulcer cases also. The next course is the most commonly known, that is endotracheal tube or endotracheal tube incubation. So in this you can see a cuff, right? So this is cuff type. You have two types, one is uncuffed and second one is cuffed. So they can ask you the advantages, because I have seen like my general surgery teacher, the professor, is more concerned about the differences between cuffed and uncuffed. When to use, where to use, how to use, all these are the regularly asked questions in his list. So it is mandatory. Please just have a look. Okay, the most important and most regularly asked question is the advantage of cuffed endotracheal tubes when compared to uncuffed is it reduces the air pollution and reduces the risk of aspiration. The advantage is it reduces the risk of aspiration. Next one, it is easy to identify because it is F in shape, similarly to this, right? That is Foley's catheter. It is useful for the collection of retained urine. Next is Fogarty catheter. Okay, this is used to remove the fresh emboli. This is used to remove the fresh emboli. Okay, so what is this? Okay, this has a halo tube. Okay, this is a halo tube. This all, and at the end you have an inflamed one. Okay, at the end you have an inflamed balloon. Okay, which helps in removal of the fresh emboli that is formed. Next is SB tube. Okay, next is SB tube. What is this SB tube basically? Okay, so SB tube is basically it contains, okay, you can insert it, okay, and it whenever it reaches the GIT junction, you need to inflame it. Okay, that is you need to inflame with this gastric balloon port, by which here the gastric balloon is inflamed. Okay, then by which you can prevent any damages. For example, if there is any trauma or damage, this can be inserted and this can be inflamed. Okay, and followed by you can inflame the esophageal balloon with this esophageal port. So whenever there is any trauma leading to the bleeding in this particular area, this will be introduced and it will be inflamed, so that mechanically it is going to obstruct the bleedings. Mechanically it's going to obstruct the bleedings. The next one is, as you have already learned so much related to the central venous fluid provision, like we have learned about the fluids and electrolytes replacement, right? So yeah, central venous fluid replacement, okay, is done with this particular catheter. And the important aspects that you have to learn related to this: it is used to supply the fluid, medication and the nutrition. It is used to detect the pressure and volume dynamics or changes. And I hope you have learned these questions. The most preferred route for in the operative room is internal jugular vein. Outside the operating room is subclavian vein, and preferred in injury and critical cases, okay, that is femoral vein, which is very easy to identify. The next comes is this hook, something like your Nibus probe, okay, which is useful for the furcation. It's almost like your Nibus probe, the working end. Okay, this is called as inducible needle. Okay, so this is a blunt point. You'll have a blunt point which is a curved needle, okay, with an eye at the point, and basically it is used to pass the ligatures around the vessels or arteries or endosomes. Okay, so this is how it is used. The next comes is, I think this is given in AIMS. Okay, this is called as Humby knife, which is used to harvest the skin graft. You can see this. Okay, you will have a knife here, okay, and you will have a roller here. So by placing on the skin, and if you roll it, if you start rolling it, it will remove the graft. Okay, so it is useful for harvesting the skin graft. Okay, the next comes is something like it looks like a cutting plier, right? It looks like a cutting plier, okay, which is used to cut the rib. It is same as the bone cutter, but the only difference it has only one cutting blade. Okay, it is useful and hold. You can identify the area where you want to remove the rib to harvest it somewhere. Identify the area. Make sure it should be away from the vital structures, and then give a blind cut so that you can remove the rib and can use it as a bone graft. Okay, thank you all. Signing off for now. We'll try our best to provide as many diagram based sessions as possible, but make a note, try to coordinate everything. But most of the diagrams what I have discussed from general surgery point of view, like what my analysis in the previous needs of 2017-18, 17 in specific, they had good number of questions on general surgery, but there was drop in 18, 19 and 20. But whatever it is, most of your general surgery questions, or most of your questions in general, most of your diagram based questions in general are not application based. Means they give a diagram, they don't ask anything deep into the diagram. They simply ask, identify this diagram, identify this instrument is useful for, that's all. They don't go very deep into the question. Like they feel like, okay, if the student knows something about this, the name, at least the name of the instrument or the name of the device, or simply the diagnosis, they don't complicate the things around diagram based questions in most of the cases. In 90 to 95% of the cases, they don't complicate the question around the diagram based stuff. They complicate the things in the normal questions, but they don't complicate the things in diagram based things. This is what my personal analysis overseeing n number of diagrams and n number of papers from different sources. Okay, if you see the mock exams of different sources, even the mock exam people or the paper setters of my team or any other team, I just randomly see all the question papers, what they give, how their thought process and everything is. But what my analysis is, they don't complicate the things around diagram based. So you also, when you're preparing, don't complicate your things around the diagrams. Just learn about the diagram, name of the diagram, and just use. Okay, don't go very deep. If it is connected for you to the theoretical aspect, to a regular question, then you can practice. The open suggestion is, for general surgery diagram based stuff, okay, for general surgery diagram based stuff, don't complicate the things. Make it as simple as possible, because you need to save time. This is how a smart student will think from the regular students. All the best.